Yeah, absolutely. These are highly relevant results. We are looking at a number of different treatment options now becoming available for treatment of BCG-unresponsive non-muscle invasive bladder cancer. And there's been a real need for additional therapies in this space. TAR-200 has been sort of one of the first trials to look at this space, and we have that's an intravesical sort of delivery system, and as more and more FDA-approved drugs become available, this is highly relevant into where this fits in. This is again a sustained delivery device that's given us as maintenance therapy as well for 2 years. So we are highly encouraged by the high clinical complete response rates that we're seeing. These are not numbers we're used to seeing in the past. We know we're used to seeing 10, 20, 25% 1 year response rate. So it's really exciting to see how many patients are responding. And as time goes by, we're seeing the duration of response. I think that's probably the most clinically relevant endpoint for patients. They want to know how long is this going to work for. We don't want a temporary fix. We want something that's working for a long time. And along those lines, then comes the, I'm sure your next question is going to be the tolerability of these treatments. And those are relevant too, not just tolerability, but also scheduling and what fits in best for the patient. So each one of these new novel therapies coming onto the scene and being available to us for use in patients have their advantages and disadvantages. Yeah, so I think overall it's been very well accepted as a concept, in a trial. It's been very easy, at least for me, to get patients' acceptance to get on the trial, because we're telling them we're inserting a device basically that's eluting a medicine inside your bladder for the next few weeks. And I've talked about this potential psychological effect of the patients leaving clinic knowing there's something inside their bladder working for a period of time. For 3 weeks, there's something that's with them rather than a single infusion. But with that, you have to juxtapose that to the patient tolerability. Nobody wants a treatment that's the mounting responses and adverse effects. And the poster that I presented here at the SUO was specifically looking at the safety and tolerability of the TAR-200 device. It's very well tolerated overall. There are very few treatment discontinuations. Of the 85 patients that you mentioned in the beginning, there were only 5 patients who had treatment discontinuation because of AEs, adverse events. So most of the AEs are grade 1 to 2. These are minor irritative voiding symptoms that we're very used to, and the patients are used to because they're undergoing some form of treatment. And we've been used to seeing these and hearing these from patients for years and years on BCG, on other intravesical chemotherapy agents. So what you want to make sure is we don't have too many serious adverse events. Unfortunately, in this study, so far we're seeing very few, and there's 9% of the patients. So basically, eight of the patients had any grade 3 AEs, and those were bladder pain. Some of them were, there was one urosepsis, one infection. So we're not talking about a off-target effect of the drug that we haven't seen before. These are related to the urinary tract manipulation and having just any kind of intravesical treatment. Again, these are things we are very accustomed to seeing in patients. So basically, the main point of the poster here was to demonstrate the safety that we've known all along, and most importantly, the tolerability of this, because this is what we take back to patients and say, they're going to ask us directly. The first question they ask is, how is it tolerated? And we can give them exactly these numbers and say it's generally very well tolerated. Very few people have it removed early due to symptoms. Most patients can tolerate it quite well. And you know, as we go along, we're learning what medicines help most. We are now making recommendations for use of anticholinergic medicines, use of bladder analgesics to help with some of the dysuria that may occur, and that's definitely helping. We, you know, always start out our discussions at meetings and lectures as, you know, radical cystectomy remains the gold standard treatment for BCG refractory non-muscle invasive bladder cancer, and yet hardly any of us are doing that as a first option, especially given the new medicines we have available to us. So as long as the patient doesn't have serious high-risk factors, and I always say, you know, be careful. You don't want to miss the opportunity for cure for a patient by trying ineffective intravesical therapy. Those patients with very high-risk, high-grade T1 disease, lymphovascular invasion, presence of extensive CIS with high-grade T1, variant histology, or these bladder cancer subtypes. So, but the rest of them, when you have CIS, for instance, yes, the patient's at risk of progression, but you know, we have an opportunity to save those bladders. And so that's become the goal has now become saving the bladder, but also, you know, making sure the patients are not progressing. So we have to be careful in using these intravesical therapies, but no question this will be in that armamentarium of the tools and the medications we have available to us to help patients preserve their bladder. Some of the patients are very elderly, can't tolerate surgery, don't want the morbidity associated with the surgery, are not surgical candidates to begin with. And so, you know, we're going to open up a whole significant portion of the population on whom we can deliver effective therapies, whereas in the past we were so limited, and the only choice we had was cystectomy. So I'm very encouraged. Can't wait to have these products, you know, completely available to us so that we can start using it outside the bounds of the strict criteria in clinical trials.